From Diamond Pharmacy Services, this is PodcastRX, a monthly show that takes you behind the counter of the nation's largest correctional pharmacy provider. We bring you conversations with pharmacists, nurses, managers, and other Diamond staff about the topics and issues we see in corrections, long-term care, and community health settings. Our chats aren't limited to purely pharmacy topics, and they aren't strictly clinical either. So if you're a healthcare provider or just enjoy healthcare podcasts, we think you'll enjoy this show. From a tender age, optics pharmacist Henry So recognized the difference that patient advocacy and education could make in healthcare outcomes. As the child of an immigrant family, Henry watched his father struggle to manage his diabetes in the face of language barriers, rigid prescribing guidelines, and uncomfortable side effects from his medication. In these difficult moments, Henry could see the need for a supportive intermediary to bridge the gap between prescriber and patient, and who could take a more patient-centered approach to care. And thanks to a chance encounter at a career fair, Henry realized that being a pharmacist could fill that role. Now a practicing ambulatory care pharmacist with Diamond's optics team, Henry is proud to be both an educator and an advocate for many of Diamond's institutional patients. In this episode, Henry talks about his personal and professional journey into pharmacy, and how his current role at Diamond has brought that journey full circle. If you're a pharmacy student, or a pharmacist looking at a different direction for your career, we think you'll enjoy what Henry had to share with us. I'm Adam Campbell, and this is PodcastRX. Henry So, thank you so much for joining us on PodcastRX. And considering the relatively short time that you've been with Diamond, I'm grateful that you were so quickly game to be on this podcast. It usually takes a little more coaxing than that, so thank you so much. Just how long have you been with us now?
Oh man, it's thanks for the introduction. It's coming up on about 10 months now, so it's been a short time, but it's definitely reaching up to the 1 year mark.
Yeah. Where did 2021 go, right?
Yeah, flew.
Yeah. Henry, what are your pharmacist credentials?
I am a PharmD. I have a BCPS and a BCACP, and I did 1 year of postgraduate training.
Nice. And that's board certified pharmacotherapy specialist and board certified ambulatory care pharmacist, right?
That is correct.
Yeah. Now that ambulatory care part of your credentials, we're gonna talk about that a good bit today. So I'm looking forward to that. But Henry, I wanted to have you on the show because when we were talking just casually not too long ago, as we got to know each other, you had a very interesting story about how you became a pharmacist, and I think it's a very good story to share with anyone who's maybe looking to get into pharmacy, or maybe if they already are a pharmacist, if they want to change their career path, or look at the possibilities of patient care. Henry, you're a member of the brand new Office of Pharmacy Therapeutics and Integrated Clinical Services here at Diamond, all more conveniently called Optics. And Optics, for those of you listening and have heard other clinical pharmacists on here, they were members of what used to be called the Drug Information Center, and that's now Optics. And we've had several of them on the show. And Chris Bender, shout out to him. He's probably got the record for the most repeat guests on PodcastRX, but he always does a great job for us. But anyway, it's always a pleasure to have our all-star team of medication experts on to break down complex clinical topics for us. And if there's one thing, though, that with the brand new Optics team wants people to know, it's that they offer way more than drug information these days. In fact, direct patient care is really the driving force of Optics. And we're going to find out in our discussion that the opportunity for you, Henry, to practice pharmacy in this way, more patient care oriented, was a big reason why you came to Diamond in the first place. And at your core, you've always been a patient advocate. And as I said, you have a very interesting and deeply personal story to how you became a pharmacist. And I think, again, talking about this journey is very useful, not just to prospective pharmacists, but to anyone who might not realize just how important pharmacists can be to the overall healthcare team. So, Henry, if we could, take us back to the beginning. How did all of this start for you, this journey into pharmacy?
Oh, man. Yeah, I think just to bring back the point of what you made of current pharmacists and students, and how this can be something that can either perk your ears or spark an interest for ambulatory care and just pharmacy in general. So I think that's definitely a good point. But just to answer your question, to keep focused, what really brought me to pharmacy actually, I know the trap or the thought is typically, what comes with the actual position, whether it be the salary or the positioning itself. But I think it's definitely important to keep in mind other reasons and drivers to kind of inspire you to be a pharmacist for the long haul, day to day, and kind of like finding what your inspiration is to be, I guess, a fairly emerging healthcare practitioner. So how I started to be a pharmacist or kind of started thinking about being one, it kind of goes back to the days of, I'm South Korean, definitely a child of an immigrant family. So shout out to all the kids out there that grew up with their parents doing the translations and, looking stuff up on the internet for them. But I know that an interesting sect of first-gen immigrants is, we definitely played an intermediary role for our parents in the range of things I've stated, but the one specific thing is definitely medicine. The first thing that I really noticed as a child was being able to tag along to a lot of different events, whether it was the DMV or the grocery store. But one specific memory that I have that kind of still reminds me of why I do what I do today is running around with my dad whenever he went to see his physician and his doctor's appointments, and kind of just seeing and gaining perspective of a very common disease state, diabetes. So that's kind of was the first step, just being able to follow along and see what's going on with my dad at such a young age. So yeah.
Yeah. What were those experiences like for you, tagging along to the doctor's office like that when they were talking about the different medications that your dad had to take? Were you having to translate those, and what? And on top of that, what was that like for him to then manage those medications? I understand you had to help him quite a bit with that.
Yeah, I mean, what it was like for me, absolutely confusing. I had no clue. It was very overwhelming. It can get frustrating when there's a bit of a language barrier, and I didn't really understand the terminology and the medical terminology that was being thrown around. So I wasn't able to really adequately translate those things. But yeah, in terms of my dad, the diabetes management was a huge piece in our lives. So a lot of the medications were not the best. It was back around the late 90s. So, we had our typical like metformin. So the one thing that I really grappled with my father was trying to, have him understand that taking this medication helps him feel better and essentially is able to produce certain outcomes that the physician was kind of trying to communicate. But really, the thing about medicine is it's hard to imagine that one pill once a day, one pill twice a day kind of just magically makes something objectively disappear or is supposed to make you feel better. But quite the opposite for my dad, actually. And I know it's a fairly common side effect for our patients out there. Metformin does cause a significant amount of GI upset. And especially if you don't take it with food, it could definitely be severe enough for people to be non-adherent to that medication. And so that was one of the struggles, and just overall the misunderstanding of feeling worse when taking a medication. So there's that, and the translation piece, yeah, definitely touched upon that in terms of just I had no clue what some of these words meant. I just knew that, hey, Dad, take this, twice a day, and it should fix something. And what it was like for him, I mean, overall, it was very frustrating. It was very anxiety inducing, hearing things and being told things that you're going to experience this, you're going to have this happen. Do you want this to happen? And, really like, I feel as though, because when I was a child and I was getting my immunizations at the same doctor, great guy, great man, treated his patients well. But I always remember that if he wanted you to get something, you're going to get it. So I remember running around his clinic and screaming and crying with my sister about getting immunization. So the thing about my father was what added on to the frustration and anger was sometimes some people are going to just say just take it. There's no solution. There's no workaround. Just take it. It's what's best for you. And yeah, I think that was something that I noticed very early on that was confusing for me. I was like, there's got to be a different way. Maybe there's a different medication, or maybe there just needs to be a different approach, maybe a patient-centered approach. So at that young age, definitely sparked my interest in healthcare and potentially the inadequacies of it.
Yeah, and how young were you, Henry?
Oh man. My earliest memories were around 4, and I do remember that was around the time that the diagnosis came through. And yeah, I believe from age 4 to 11, I was trying my best to kind of just make sense of things, whether it was the medications and the diet and the overall issues with just going to the actual visit itself. So yeah.
Yeah. And after that, after the experiences with your father, when did you understand that being a pharmacist could be a path to that better way that you just talked about?
Yeah, I think the first time I quite realized what a pharmacist is and what they do was when I went to a career fair out in Gettysburg College in South Central PA. And I do remember meeting, like chiropractors, nurses, accountants, but I'll never forget meeting that one pharmacist who kind of just sat us all down and just explained to us that they're kind of like a community guardian, a filter, if you will. There's many, if you drop a pharmacist down on a map and they have a certain radius of, communities that they cover or a community that they cover, they act as a guardian to their patients who, when penicillin comes through, they know that their patient's allergic. They know that if this one patient has, let's say a female has resistant hypertension and a provider, prescribes minoxidil, which causes upper lip hair and other unsightly hairs, that pharmacist knows you. They know that you don't want that. And he kind of just explained to us that, hey, not only are these medications or something that fixes the problem, there also needs to be something that kind of walks hand in hand, and that's communication skills, motivational interviewing techniques, teach back methods, and that overall explanation and understanding of, how patients can actually become empowered to understand their disease state and their medications. That really inspired me because I didn't quite realize that those were tools that were available for patients. And I've personally seen after this event the power that education has for a patient. And yeah, since that college fair, I was pretty much sold on the idea of pharmacy.
Yeah. And going back to the experiences with your father for a second, now you were 11 years old and your father passed away, that right?
Yes.
Yeah. Now, you're very young then, and of course, would be several years later that you realized the pharmacist, the importance of the pharmacist in that. But can you remember anything of what it was like dealing with the pharmacist when your dad was still dealing with his medication issues?
Oh man. Yeah, I do actually remember. It was, everyone knows that going to the pharmacy is an absolutely hectic event. And when you go in there, everyone's crying, sneezing, yelling, and it could be a little hectic depending on how busy the store is. I personally remember there was really never the time to kind of ever see an education session. I just remember it was a quick in, quick out kind of thing, and it was not the best experience from what I could say.
Yeah. And now fast forward back to you had just seen this career presentation about pharmacy and you knew that's what you wanted to do. So when you finally got into pharmacy school, excuse me, when you finally got into pharmacy school, well, where did you go to pharmacy school and how did you get on that path to furthering getting right into the trenches of pharmacy?
Oh man. So I went to the Philadelphia College of Pharmacy in Philadelphia, established 1821. We're the first pharmacy school in America. That's like one of the first things they teach us in the pharmacy school that I went to. And yeah, it was a 6-year accelerated PharmD program. So you pretty much jump right in. And how it usually goes is they give you kind of the background science and knowledge for you to understand how to be a pharmacist before you even start stepping into clinics and internships and other clerkships. So the first thing that I went through was chemistry, biology, organic chemistry, biochemistry, a lot of different humanities and intellectual heritages, where basically we combine the sciences and the overall plight of humanity, etc., to try and kind of be a very down-to-earth and humanistic healthcare practitioner. So throughout those 6 years, just to kind of support my way through, because it's hard to I suppose have fun in pharmacy school without working. So I pretty much worked full-time at a fairly large chain, and was able to experience firsthand what it's like to be in a pharmacy when it's hectic. People don't really want or have time for the education. So it definitely wasn't a very promising direction in terms of where I was going at the time.
Meaning retail.
Yeah.
Okay.
Retail was tough to deal with.
Is it true that you were surprised how just much applied science went into pharmacy?
Oh, definitely. I really thought, kind of pharmacy was just something you just kind of did, and it's hard to explain because the stigma with pharmacy is a lot of, you guys just count pills, right? Do you remember how to count to 5, 10, 15? So a lot of those thoughts and mentalities kind of shifted onto me. So I was absolutely shocked whenever I had to sit down and review kind of like all the different course materials and syllabi. And yeah, I just had no clue that there was so much knowledge that goes behind being a pharmacist. And yeah, there's a lot of different classes that I could definitely add on to. We had biostatistics, we had pharmacokinetics, pharmacodynamics, and a lot of those different sciences kind of really do tie into my current day-to-day, whether it's a calculation or understanding a chemical reaction that might cause a certain intravenous drug or tablet to maybe become, unstable a little bit quicker. So yeah, definitely surprised, but the applications have held fairly true at this point.
Yeah. Now, okay, so you're in pharmacy school right now. You're working part-time at a local retail pharmacy, just getting, the understanding of the practice. But right now this isn't what you want to do with your pharmacy training. Pharmacy is still what you want to do, but this retail and this lack of opportunities to empower patients, as you were seeing, is not what you want to do. So when then did the idea of ambulatory care pharmacy, when did that come into play for you?
Oh man, I think it's got to be one of my favorite preceptors in the past. She was a board certified ambulatory care pharmacist, and it was one of the first lectures that we had for a course called pharmacotherapeutics. And pharmacotherapeutics basically just ties in pharmacology, or how a drug works, like how the molecule affects a certain receptor that has a certain effect. And cotherapeutics or therapeutics is just a combination of whether it be a treatment guideline or clinical literature, and how to apply those pharmacologic agents to the therapeutic guidelines. But basically, this professor was a little bit different than the other board certified pharmacotherapy specialists that I encountered in lecture. And the difference to me was, not only did they teach about the pharmacology, the therapeutics, but the additional points that I remembered were many different types of teach-back methods or different ways to confirm learning, and a huge emphasis on teaching patients about how do you go about teaching the patient the disease state, highlighting what the common side effects are, how to manage those common side effects, when to escalate level of care, and just overall having the patient understand, what this medication is, what it does, and how it's going to affect you. And also making sure that they keep in mind the price and overall patient preference in terms of packaging all of those that data together.
Can you please explain what ambulatory care is?
That is a great question, and I actually made sure I have the best definition that I agree with, and that is from ASHP. And basically, it states ambulatory care pharmacy practice is the provision of integrated, accessible healthcare services by pharmacists who are accountable for addressing medication needs, developing sustained partnerships with patients, practicing in the context of family and community, and it involves being an integral part of an outpatient clinic, multidisciplinary healthcare team to ultimately improve quality and patient outcomes by focusing on medication management. So many different hats. I could list off many other things. For example, services ambulatory care pharmacists provide, care coordination, chronic disease state management, comprehensive medication management, drug information, healthcare provider education. The list goes on. There's so many different things that we do. But yeah, that to me is kind of an ambulatory care pharmacist in a nutshell.
So after that great experience with the preceptor who turned you on to these ambulatory care principles, and what was your first foray into doing that professionally?
Yeah, I think my first step into doing that professionally was walking into an internship that basically managed HIV medications and just talking to patients about what these different numbers mean and how they impact their lives, and how it affects how they feel as well. And that kind of was like a loose introductory experience. I kind of then went on to work at other places outside of retail. Since I kind of grew past that phase, I actually worked at a hospital, a comprehensive cancer institute that had a meds to beds program that we actually went to the patient's room and discussed as interns with a pharmacist preceptor supervising, basically just counseling points, talking about opioid use, since these were mostly cancer patients, and how to involve their family in terms of things like naloxone whenever they may have inadvertently taken too much. So those couple steps that I made in terms of deciding to do a pharmacy school sponsored internship as well as a personal internship with the cancer hospital kind of really opened the door to something that I really made sure that I wanted to do. So yeah, that was kind of like the introductory experience, and it's kind of branched off from there.
Yeah. How about when you got out of pharmacy school? What did you do?
Oh, so when I got out of pharmacy school, I actually applied and matched with the residency program in the greater Philadelphia area. And that was my first step into kind of the real world and understanding what medicine really is and the practicalities and the time constraints of medicine basically is. I think what residency taught me up front before I really go on to the experiences, and this is especially for the students out there, is just learning to be grounded. You definitely have kind of like a save the world mentality where you want to make every intervention, grab every provider's attention and educate them the best that you can. But, overall, it's really difficult to get everyone together and kind of on the same page in terms of healthcare and kind of what's best for the patient. So, yeah, but residency definitely was a great experience in that, we have something where we actually have to do two different research projects. There's a national research project as well as a regional one. And I selected one that had to do with ambulatory care. And I think that kind of really prepared me for my current role with the optics team, basically ranging from study design to accountability of patient data, and essentially asking the right research questions. So what I did was I did a transitions of care or ambulatory care research project on COPD patients. And for those that don't really understand the impact of COPD, CMS has defined about 6 different disease states, maybe 1 or 2 are recent, where disease states like COPD or chronic obstructive pulmonary disease, pneumonia, CHF or heart failure, coronary artery bypass grafting, total hip, total knee. Those disease states, if they are discharged from your hospital and readmitted within 30 days, there's a lot of financial reimbursements that are lost in that process in those events. So we had a huge problem with COPD readmissions, and it was something that we really wanted to fix. So what I did was I basically came in as a transitions of care pharmacist / ambulatory care pharmacist. We pinpointed patients that were frequent flyers, and we wanted to get those numbers down. And what we used was a coordinated approach with the pulmonary team and the respiratory therapy team, the nurses, and the attending physicians. And we basically set up sessions where we provided intense discharge counseling tailored to the patient. We did inhaler technique assessments, and we had patients perform teach back. And yeah, basically what we did was we were able to demonstrate a somewhat lesser of a reduction of COPD readmissions. And yeah, that basically was a really good experience for me in that sense. After that, I went on to work for a fairly large health system in PA and was pretty much a floor pharmacist at all times, especially on the cardiology floors. And that's mostly because I staffed as a resident on the cardiology floors, seeing a lot of our heart failure patients. And yeah, basically I was basically able to see, what the real world had in store for pharmacists as well, in a new health system, in a new area. And it was really interesting because we were integrated into the teams, but for lack of better words, not utilized to our fullest degree of our knowledges and abilities. So that was a bit of a interesting time to grapple with as a pharmacist.
Remember the Diamond Drug Information Center? That group of expert pharmacists who help Diamond customers with their medication questions? Well, I'm here to tell you that they're a thing of the past, but not in a bad way. No. The Drug Info Center has a new name and a new mission. We're proud to introduce the Office of Pharmacy Therapeutics and Integrated Clinical Services, or OPTICS. Instead of offering just drug information, the pharmacists of OPTICS are moving their services closer to direct patient care. Whether it's through collaborative formulary management, medication therapy management, or individual patient care plans, the OPTICS team is ready to integrate their clinical pharmacy expertise into the day-to-day operations of medical teams in corrections and long-term care, and they'll continue to offer the same drug information resources they've provided in the past. To get a clearer view of OPTICS and its mission, go to diamondpharmacy.com/OPTICS team to learn more. Now back to PodcastRX.
It seems, though, that this ambulatory care track for you, Henry, that is the best way for you to have fully realized that patient advocacy streak that goes all the way back to when you were helping your dad with his medications. Is that fair to say?
Yeah, I would definitely say that. I mean, I think a couple of points that I should tie in. Definitely think that patient advocacy is a huge thing to keep in mind. When I was younger, and I think I know I harped on it, I do always remember the side effects that my dad dealt with that were so intolerable that, he kind of decided that this isn't something I'm going to be taking. And sometimes the question needs to be asked, is this what the patient wants? And so that's kind of what I carried with me throughout my experiences, and linking it to my time at a large health system or hospital system. And what I would always ask myself is just kind of, is this what the patient wants? And is there any way that I could advocate for them? And there's many different examples of this, but I think some of the best examples could be what I mentioned prior. This is definitely something that happens from time to time and has happened to me personally. We had a patient who had very resistant hypertension and was prescribed one of the last line agents, minoxidil, and it causes unsightly hair to appear. And she was a female, and I just made sure, hey, you've been in and out, and I know that you don't want to come back in here, but this new agent, the minoxidil, may potentially cause you to grow some facial hair. Is this something that would stop you from taking it? And essentially she said, yeah, I definitely would stop taking it. So just using information like that. And in terms of advocating for the patient, I think one of the points that I know from different patient advocacy groups, keeping the entire team informed is one thing. Just making sure that you have many different input and perspectives relative to the drug therapy and the patients and how they feel. And that's one of them. And another thing you can incorporate into that is even cultural and religious beliefs. That's something that we as the optics team deals with from time to time. And there are some drugs out there that actually contain pork products, and that's definitely not something that would be desirable for someone of a certain cultural or religious background. And different things like that, highlighting that preference and having the team understand that this is something that we need to make sure is okay with the patient. And overall just understanding that social and financial issues are something that we should keep in mind as well. I can't tell you how many times whenever I was a resident and performing my research project for COPD, we would prescribe an agent that wasn't even close to being on their tiers of coverage for their health insurance. So, whenever we did a mock script or ran a script with the local retail pharmacy or a contract with pharmacies, you'd find that some of these patients would have to pay a copay $300, $400, $500. So that's another huge thing that we need to keep in mind, thinking about what the patient needs in terms of those sectors as well. So hopefully that answers your question.
No, certainly does. And everything that you've mentioned about the ambulatory care pharmacist and their role, it's a win, and it's a win for patients, it's a win for pharmacists. Now, it seems though that they're not incredibly widespread in healthcare overall. Is that a correct assumption?
Yeah, I would say that definitely, at least in our area, it's not something that's as common or integrated, although I will say there were a couple health systems in Pennsylvania that integrated up to 250 different pharmacists into their primary care clinics. And basically they would take on, for every individual pharmacist, they would take on about 10 different providers and aid them in, basically everything that I'm talking about. But yeah, I think the thing is, and it's something that I always try to think about, the impact of a pharmacist and what we do. I think what we essentially provide in the most simplest way is we are an intermediary force. Whether the information travels down from the physician to the patient or whether the patient communicates information up to the physician, we stand in the middle essentially, and we interpret whatever the physician states and all their different medical jargon. And the little kid in me that didn't understand anything about anti-diabetic therapies and hemoglobin A1C, and the list goes on. There's so many different things that makes your head spin. Taking all of that information, providing it and basically transforming it into digestible educational points for the patient, and providing documentation and providing learning pools and references, and even your clinic phone number or hours. You're basically passing that on as a filter or some sort of intermediary for so that the patient can understand it. But the other thing that we do too, and this is something that definitely ties in with the idea that, pharmacists are also researchers and scientists as well in their own respects. We have a really great way of collecting pertinent data points, whether it's, let's say, for example, and especially for the listeners out there that understand this, let's say you're on lisinopril or an ACE inhibitor and you develop that nasty dry cough. You kind of telling us, oh, I'm always coughing, but, and I keep going to the ED or I keep going to the hospital and they're just telling me that I'm fine. There's nothing wrong. My white counts are this, or my fever, I don't have a fever. But for us, we know that it's very common to have a dry cough with ACE inhibitors or lisinopril. So we digest that the way we can. We transform it from, I just cough here and there. But we link it with the fact that we can find the specific targeted agent that causes this, and we deliver it to the physician and say, hey, your patient's experiencing this. They're educated and they know that it's causing this. They may discontinue it, or this is something they don't want to have. Can we switch it to something more feasible for the patient? So yeah, just overall understanding that, that's kind of like the first step, like physicians and patients understanding where do we fit between literally physicians and patients. And I think it's getting to be fairly well understood, especially since as I just stated, there's a lot more pharmacists being embedded into primary care clinics. But yeah, I think it's definitely, a win-win for both the patient and the physician in terms of the best information is traveling both ways.
Yeah, I would agree with that. Now, going back to your professional journey, at this point, you're still working for the health system, or I'm sorry, hospital system. And so now, where does Diamond and the optics team come into play for you?
Yeah, I think that's a great question because everyone moves and graduates and leaves for a reason, and I think the reason. So when I was rounding the team, we did both, early morning rounds and then discharge planning rounds, and basically the hope was to kind of gain understanding. What did the patient experience throughout the stay, and during that time, the first rounding session, I would always, let's say, for example, we have someone who's a new start for heart failure drugs, and they're on this very heavy duty beta blocker, and I see a few bouts of, let's say, a heart rate of 54 or 55, which is fairly low. And then, some notes specifying that the patient almost fell or did fall. That kind of links with me how I need to discuss with the team and advocate for the patient. Hey, I don't think this was the best dose, or this is the best dose. Can we decrease it, or can we have different techniques to kind of eliminate those risks? For example, there's some beta blockers that need to be taken with food to kind of prevent different drops in heart rate and blood pressure. But basically, I guess, where Diamond really came into play was I kind of came to a point after talking to, physician champion after physician champion, stakeholder after stakeholder. Everyone cares about readmissions and reimbursements, and especially a large hospital would as well. But I don't think their scope or their vision was quite on pharmacists as a potential fix. Whereas, when I met up with Diamond and I spoke with them and I interviewed with Zane and all the other key players at Diamond, I was informed that, not only would I be performing a clinical role as in providing managed care, preventative cares, different things like drug information mostly, but we're also going to provide ambulatory care services and medication management services for a population that is underserved and very, in my opinion, very deserving of the most optimal healthcare that provides both the best outcomes in terms of morbidity and mortality, but also directly providing the best outcomes for the actual institution that they're held within. So I was when I first talked to that team, I was immediately sold on the idea of Diamond and optics.
Now, when you finally get here to Diamond and you start diving into the caseloads and whatnot, you're working, as you said, with a different population than you're used to. You know, you were working directly with patients. Now, with patients here who are in correctional facilities, long-term care facilities, you're not directly interacting with these patients. But so, what was that like then for you to adjust to that? And then on top of that, then how were you able to apply everything you'd learned so far and see that yes, you are being still that patient advocate despite the lack of up close and personal interaction?
Yeah, I mean, that's a great question because it's actually pretty tricky how we do things. We do things remotely, and we're in contact with the providers almost all of the time. But let's say this. I would say that when I was in a clinical pharmacist role in a hospital setting, um, the data was all at my fingertips and everything was there for me. I could see all the different information where, if this agent was administered, I could see a specific drop in this value or an increase in this value, and it was great. And, the providers were right there. But, as a clinical pharmacist in that setting, especially a bigger hospital, I do remember my patient caseloads were, oh gosh, I remember it ranged from as low as during COVID, 17, as high as almost about 150 different patients. So it was definitely a touch and go, and definitely didn't get to review in depth my patient population on that specific floor. And I guess what I lacked there, and this is kind of going to tie into how we manage our patients currently at Optics, there was just a lack of continuity or longitudinal care. And whatever minute or major intervention that I had for a patient, I really didn't know how they did until they came back in again. And that's something that that was really important to me because, I really do care about, our patient population. And for anyone out there that's listening, that's a pharmacist currently that has a cult following, and students for you out there, you're going to meet that pharmacist that has a quote unquote cult following. You as a pharmacist is eventually, when you're trusted and, you say, hey, Mr. Smith, hey, Miss Smith, how are you? How's the kids doing? How's your grandkid doing? All those different things. You integrate yourself into a patient population and know them at a personal level and at a medical level. And that is something that's super important. I've even personally known groups of patients leaving a community pharmacy to follow a specific pharmacist to wherever they landed that next. And yeah, so that is something that was absolutely important to me, that I lacked at that setting. And so yeah, once I got to Diamond, the interesting thing, and it definitely ties into what I was saying about the call following, is that even though I don't have quite the face-to-face interaction that I would like, or that is possible, I definitely get to see what kind of impact my interventions have on our patient populations. And some of them are very apparent. Like, for example, let's say a patient didn't have one of their medications continued forward, and they're experiencing symptoms relative to their disease. That's something to see, something that's nice to see when there's a nursing note or physician note where a patient says something along the lines of, I'm feeling a lot better. I'm glad that I was able to have this medication continued. Ranging to the things that we really don't see. Like, for example, a lot of our patients these days, especially in certain underserved settings, are not fully vaccinated to what the CDC kind of recommends. So, I look at it this way too. If I see a full year or two without any events for pneumonia or shingles, that's another thing that is important, because that didn't happen potentially because of a recommendation made based upon different, risk factors that the patient falls into. So I think overall, the best part of optics is just not only are you able to make those free and open recommendations based upon evidence-based medicine to the providers, they're willing to listen to your expertise, talk to you about it, the risk, the benefit, and pretty much take that recommendation and initiate whatever agent that we specify. Sometimes it doesn't always work out that way, but we're able to see those direct, tangible benefits that the patient experiences. And that's something that's really important to me, because I always am following my patients to see how they're doing, see if their A1C dropped, see if their blood pressure is finally trending down. So yeah.
Yeah, and many times you're able to be that patient advocate when they can't advocate for themselves.
Yeah, definitely. I mean, great example in terms of transitions of care and different initiatives that I'm aware of. Like medication reconciliations are extremely important these days, because reconciling medications from different pharmacies, different physicians' offices, that's really important, because there's some medications that are missed. And like that's a great example to highlight in terms of an intervention that we can make that helps the patient significantly.
Being that you're so new to the optics team, what kind of things do you personally like to see the team get into as optics really takes flight here? I mean, if for those unfamiliar, and we may we're supposed to have an episode on this, with the optics team, but for those unfamiliar, optics is rolled out in October of 2021. So, you guys are still doing the drug information thing that, under the Drug Information Center that all started. But now that you're getting more into the patient care, what kinds of goals and ambitions do you have for the group as a whole?
That's a great question. I think one of the first things that I discussed with Zane and a couple other key players at Diamond was hopefully trying to integrate ourselves into more ambulatory care services. Not a lot of patients actually know that ambulatory care services are covered by your insurance, can potentially even help lower copays and different costs by just pretty much scheduling a 30-minute or 1-hour session where the pharmacist kind of sits down with you. They can FaceTime you, they can call you, and especially because of COVID, those kind of face-to-face encounters that qualify for this type of service kind of has been eased a little bit. So I think what I would like to see is a little bit more involvement with our communities. And I think it's something that we all definitely understand the significance and importance of. But I think what I want to do is, I'm hoping that, for anyone listening out there that kind of thinks, maybe my medications could be a little bit better. Maybe there are certain things that I wanted to say, but I wasn't able to say. I kind of challenge patients to kind of look into it and understand, where do I stand in terms of my ability to get coverage for, ambulatory care services or medication therapy management more specifically, and how that can impact your life essentially. And yeah, like I hope that overall, as we progress in terms of healthcare, population health, medicine, I hope that pharmacists are looked to more often, not only as a reference or someone to kind of pick something up from, but so like a go-to, or like an advocate, a guardian angel, someone who's willing to have their eyes on you at all times, and not only their eyes but ears on you as well. Being respectful of your culture, your religion, and understanding that not only do we want what's best for you, we want what's best for for your family, because there's many different things that inspire patients to be healthy. So I definitely hope that we can expand ourselves into more community settings and just kind of spread awareness that, hey, there are people out there who are looking to not just add on agents to your life or anything like that, but just optimize your life to the best that it can be, and help you with preventative care in terms of immunizations or even other pharmacotherapeutic agents. And so that's definitely something I would like to see, just reaching out into our communities and having people, come to us and say, hey, yeah, I'm fed up, I'm lost, I don't know what else to do. I just need someone to sit down with me and just teach me about what this does, what that does. And yeah, that's something that's really important to me and relative to my history.
Yeah, I was just going to say that really ties everything together, because you would have certainly liked that, a pharmacist like that with that mindset and that skill set. I'm no doubt you would have certainly liked that back when you were helping your father with his medications.
Definitely.
And now you get to be that for someone else.
Yep, definitely.
Yeah.
And sorry, go ahead.
I was going to say that mission that you laid out, what you would hope to see optics achieve, is really interesting, and we certainly hope that is the direction that you and your colleagues are able to go, and again continue to show just how important pharmacists are in the overall healthcare team.
Definitely, yeah,
and the tangible effects they can have on patient care. Henry, so I want to thank you so much for sitting down to talk about your journey as a pharmacist. Again, I think it's very instructive for anyone who's looking at a pharmacy career or is in the midst of one. You really illustrate what pharmacists can do beyond just counting the pills, as you said. And we really appreciate you sharing your time and your expertise, and we wish you continued success. You've only been here, again, 10 months, so you got a lot to do, and you're a busy guy, so I don't want to keep you anymore. But I do hope that you will join us on a podcast again.
Will do. Thanks so much for having me.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRX is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com.